Okay, good evening and welcome. I am your host, Lauren Gates, for tonight's Airway Health Solutions Conversations, Airway Orthodontics, with Dr. Bret Christensen, our newest faculty member. I'm so excited to have you here. Welcome, Dr. Christensen. How are you tonight?
We're good. Nervous when I hear that 300 people are going to be listening tonight. But
well, actually, I'm thrilled that there are 300 people registered. It doesn't mean that they're going to all be on tonight, so don't get worried. But what I love about this is there's so much interest in airway orthodontics, and I am so glad that you are the presenter tonight because you are an orthodontist. I'm going to just give you a little background here about your bio. So for those who do not know you, Dr. Bret Christensen is a practicing orthodontist of over 30 years. He's a diplomat of the ASBA, which is the American Sleep and Breathing Academy, and one of 5 orthodontists to become board certified in sleep medicine. I love that. Dr. Bret Christensen attended Creighton University School of Dentistry in Omaha, Nebraska, and a Doctor of Dental Surgery in 1993. Christensen completed his orthodontic residency at the University of Louisville, Kentucky, where he not only received a specialty certificate in orthodontics, but also received a master's degree in oral biology. In 2019, he received diplomat status with the American Sleep and Breathing Academy. So welcome. And what I can't wait for everyone to hear is not so much your credentials, which are so impressive, but your journey. And I know you have a very special presentation for us tonight. We do have a lot of questions as well, because I said there's a lot of interest. But before we kick off your presentation, it is National Orthodontic Health Month, and it's actually National Dental Hygiene Month and National Physical Therapist Month. So we have a lot going on in October. But we specifically chose this time spot because we're talking about orthodontic health. And before you kick into your presentation, when you break down the word orthodontic health, what does that mean to you? And then perhaps we can kind of segue into your presentation.
it used to mean giving everybody a pretty smile. And now my whole focus of everything is changed to actually nasal breathing and helping kids to have an open nasal airway. And then correcting sleep apnea, sleep disorder breathing in as young as 3 years old to, I'm treating people in their 90s. And so my practice is a huge practice. And so really, as I look at it, it's the foundation of what orthodontics really should be versus the teeth. I had patients in today that, I said it used to be that we just focused on the teeth and that little, it's like focusing on a leaf and on a tree in the woods and not seeing everything around you. And now when you go into sleep medicine, you look at everything around you and the last thing you see is the leaf and the teeth. And so fixing the teeth is easy, but getting everything else around it, working together for a healthy individual is what matters.
Well, what I'd like to do is just take a quick poll here on who's joining us tonight. I was only allowed a few options to list all the professions. So I'm going to launch this poll because I want to see what professionals are with us this evening. And I'm sorry if yours isn't listed, you can put it maybe as other allied and put in the chat perhaps. I only had certain options. So I know we have a lot of different specialties here. Let's see what we got. Give it a couple minutes. Okay, so it looks like we're heavy on the dental, the myofunctional, the dentists, and the orthodontists. We have about 5%. So what I'm going to encourage everyone on this call today, this conversation, is you'll get the recording, is perhaps send this over to your local orthodontist, whoever you work for, your orthodontic colleagues, so we can spread the message as well about airway orthodontics. Okay, well, I'm so excited to see your presentation because I've seen some of it, but not all of it, and I'm really excited. Tonight, we're just going to focus on the pediatric component, although you do expand adults. Yes, you can do expansion, and we'll answer some questions on that, but we're going to have you come back to focus just on the adults because the pediatric, we can only do so much in 30 minutes. So you have the floor, Dr. Christensen. Thanks again for being here. Why don't you go ahead and share your screen and we'll get rolling.
All right, we're going to do that, hit share. All righty, so let me just go on to This is the first thing is people always want to know, why do you do what you do? And so turn your volume up on your computers so you can hear this. And this little gal was actually just in my office. I just left her. She's in what we call phase 1B right now. But this was her a few years ago. And this is a video of her before we started to treat her. So. Okay. This is her a week into it. Mouth still open right there. This is her 2 weeks into it. Mouth closed, breathing through her nose, but still pretty constricted on things. You can still hear. Okay, and this is 4 weeks into it. Mouth completely closed. You can hear a little bit, but not much. And she's totally relaxed, and her whole sleep pattern and her whole life. So let's talk about my journey, where I started out. I was trained at University of Louisville, and in our training there, if you didn't have room for teeth, you took out 4 bicuspids, and sometimes you took out molars, and everybody got wisdom teeth out. And I was trained in headgear to push back on the upper jaw. My first couple of years out of orthodontic training, I was actually taught orthodontics at Fort Bragg in a residency program there. And then I moved to Lewiston and started my own practice. And I treated patients this way for 7 years. Some of my early patients was one of my daughters that I treated, and I did headgear on her. And now I'm undoing what I did with her 20 years later. But as I was treating my patients, the only time that they ever told you to take or to expand is when you had a crossbite. And so when a kid came in with a crossbite, we would put in an expander. And what I noticed on my kids that I expanded, they had enough room for their teeth after I expanded them that I didn't have to take out teeth. And so I said, well, you know, if I can expand these kids and not take out teeth, let's do more expansion. And as I did the expansion, I would have parents come back to me and they would say, boy, ever since you did that expansion on my kid, they used to snore. Now they don't snore. My kid was on ADD medicine, and now they're not on ADD medicine. And I blew it off for quite a while until I kind of got to the point where I said, okay, let's go ahead and go a non-extraction practice, and let's not take out teeth anymore. And when that happened, the stories and the parents that just flooded, I mean, on a weekly basis would come in and tell me, hey, my kid is no longer snoring, and my kid is sleeping better, and they're doing better in school. I had to pay attention to that. I was using both the Forces appliance, which is a spring that helps the bottom jaw to grow forward, and I was using headgear. And I just struggled with the headgear ones to get compliance. And when it got done, they were still class 2. And yet when I used the Forces appliance, they were corrected that way. The other thing is when I had numerous patients that when I extracted 4 bicuspids, especially the upper bicuspids, by the time we're done and retracting all of those incisors back, we didn't have very much of the root left, and we had a lot of root resorption on there. And these cases, they seem to just take forever. And so in probably around 2010, is when I just said, I'm done. I'm no longer extracting. I'm no longer using headgear. And since then, it's been a whirlwind of just learning more and more and more. And there's so many wonderful people out there, so many doctors that are up on this that you can learn from. And so my question is when I look at my patients now, everybody that I treat in the orthodontic world, it seems like everybody that comes in has a bad airway. And I've had people that have said, well, you just think everybody that's an orthodontic patient, needs an expander. Well, what are the reasons why somebody needs expansion, or why did they even go to the orthodontist? And the number one reason is they got crooked and crowded teeth. Well, if they got crooked and crowded teeth, then they've got underdeveloped jaws. If they got underdeveloped jaws, they're going to have underdeveloped nasal airway. And so, you research everything. You say, well, where does this come from? Why are there so many orthodontic patients? And is it something that happened embryonically in their embryonic development? Is it because they were breastfeeding or not breastfeeding? Was it the food they ate? When they were developing, did they eat soft, squishy foods, solid foods? What about the tongue function? Before 2019, as an orthodontist and as a dentist, I never looked at the tongue. And now that I'm looking at all of my patients, and I screen every single patient for airways, we find out that probably 90% of orthodontic patients have some form of a tongue tie. And, is it a posterior tongue tie or versus an anterior tongue tie? And is the mandible, why is it deficient in growth? Is it because of the maxilla? And so what can we do as doctors to make things better? Do we just focus on the teeth and make things straight, or do we look at the whole patient? And so my question was always, where does the airway start? And I know there's a lot of different opinions out there. And tonight I'm going to focus on the things that I can make a difference on. I realize that I think the food that we eat is super bad in our society, but I'm not going to be able to change that. And the things that I can make a difference on is what I focus on in my practice. And so I'm going to show you a video. This is my grandson when he was 6 months old, and I was sitting in church. So if you hear some talking in the background, you can ignore it, but pay attention to what he's doing at 6 months old.
She did something, but you don't necessarily earn or qualify.
Trying to get him to breathe through his nose.
It's different. Yeah. Less
Struggles.
Border, very, very different in many cases.
Well, part of it is very too illegal that you can't use. Trust them.
As soon as I let go, that mouth just pops right out his back mouth.
Qualifying for blood.
So this is a he was like 6 months old there and struggling to breathe. And this is my own grandson. So as I look at all of these patients, I think a lot of this stems from how the tongue functions. And as we look at embryonic development, the tongue starts to form at 4 weeks, the maxilla at 7 weeks, and all of those, the sutures and growth plates and everything like that grow by interstitial bone growth. And they grow by not only genetics, but like the upper jaw develops with tooth development, interstitial bone growth, pressure of the tongue, swallowing, and if it doesn't have pressure, and it doesn't develop correctly. And so this is a picture. I was asleep last night, and at 3 o'clock in the morning, I woke up and I said, I've got to put some pictures on. There was a day back in 2019 that I said, I'm just going to go take pictures of my patients in my practice. This is one day in my practice. And I took pictures of just a hodgepodge of patients, and this is what I came up with. And this is so common every single day when I look underneath the tongues, and I'm amazed that nobody ever did that. I wasn't trained in that, but the majority of our patients are tongue-tied. And so if this is just a random sampling of our patients in one day in the practice, what is going on with our population? And so when I look at this, I say, when should we treat a tongue tie? And I'll get into more of the tongue function stuff later, but when should we treat a tongue tie? And really the idea is to get it as early as possible. I have a baby coming in tomorrow that was born on Sunday, and they're going to come in and we're going to release their tongue tie. I think I've got 4 babies coming. And if I can get that baby functioning correctly from birth, and that tongue can push up into the palate and do what it's supposed to and help the upper jaw to grow, the nasal airway to grow, and they can grow right, then I'm going to eliminate the number of patients that I need to treat as an orthodontist. And so this is what we see. Like I said, I have 5 babies coming tomorrow, and this is really common to see all these little tongue ties. If they have a tongue and a lip tie, they don't breastfeed correctly. Their upper lip doesn't flange open. They don't get a deep latch, and they need that deep latch for that first year and a half of breastfeeding to get that breast tissue in their mouth, and then their tongue to push up against the breast tissue. And as that tongue pushes against the breast tissue and into the palate, then the upper jaw grows correctly and the nasal airway grows correctly. And so this is just another illustrative of what happens when your lip doesn't lift up and how shallow the latch is going to be. And so when you see somebody that's got a tongue tie, and it is tied to the bottom of the mandible, what happens is if that upper jaw doesn't grow, neither does the nasal airway, and these kids are going to become mouth breathers, and then they drop their bottom jaw as they drop their bottom jaw, then the mandible doesn't grow forward, because if the mandible's hanging there as a airway, it's not being stimulated to grow forward. And if you look at the orthodontics, 70 to 80% of orthodontic patients are class 2. And it stems back to how their faces grow and how their airways grow. So as we look at patients, when should we treat them? Now this next slide is and this is going over multiple studies to see where facial growth and development is, percentage of growth in the craniofacial complex. And if you look at it, between 0 to 2 years old, 54% of your facial growth and development is completed by the end of 2 years. By the time you're 5 years old, you're at 76 to 80%. Those first few years, your birth to 4 to 5 years old is your most critical time of growth. And so if you can get somebody developing correctly right off the bat, then you're set. But like my grandson, I wasn't looking at tongue ties. He was very tongue tied, and even at 6 months, he was reserved to be a mouth breather. And so when we look at the nasal airways, years ago, I went to a sleep study meeting with Sleep Group Solutions, and they had this machine there, and it was called the acoustic rhinometer and pharyngometer. And while I'm in this meeting, I asked them, I said, so if, and they were teaching us how you can say, okay, you need to refer this person to an ENT. And if, and then the pharyngometers to help you, decide where to place your appliance. But as we're looking at the nasal airway part of it, I've been seeing these patients, and I've been seeing that I've been improving their nasal airways. I raised my hand. I said, hey, can you use this on kids? And I really got pretty much blown off and said, hey, we're here to talk about adults. I don't know about, kids or anything. I said, is this machine, it just measures size, right? And they said, yeah, it measures the minimum cross-sectional area and the volumetric size of the nasal airway. I said, so this could be actually used on kids to measure that. And they said, yeah, but we've never done that. And so what I did is I bought the machine and I brought it home, and we instituted back in 2013 that we would test every patient that we had ever walks in the door and just see what their airways are, to see where they're at. And we've gone through many different styles of the Eccovision Rhinometer and Pharyngometer, and we're now at the one where it's a Windows based, and you'll see some of the studies that I've did earlier that are DOS based, a different format, but they still do the same thing, and they just measure the minimum cross-sectional area. Well, out of that, I looked at patients and I said, okay, what is the size, what's the minimum cross-sectional area of an adult? And if we have an adult and we know what the growth pattern is of kids, by 2 years old, they should have 50%, roughly of their airway, of their facial growth and development done. So they would be at about 3.2 millimeters or 0.32 centimeters of minimum cross-sectional area. And then I've used that other data from the growth things to come up with this chart right here that shows where you should be at different ages. And notice in the first 2-4 years, you have these really big jumps, and then it slows way down as you get older. And so on here, and I'm happy to give this to anybody so they can see what it is, but the minimum cross-sectional area is one part of it. And then the next part is the volume. This is the cubic centimeters of air that can flow through each nasal passage. And so we have used this to measure every single one of our patients, whether they're come in as a 3-year-old or if they come in as a 70-year-old. And you would think that as you get older, these would be better. But I had a lady in today that, trying to remember what her age was. I think she was in her 50s, and she had basically a 3-year-old airway. And she had crooked and crowded teeth, and she's struggling with clenching and grinding and all these different things. And I explained to her, I said, you've been doing this your whole life. And so knowing where they're supposed to be and then guiding your treatment so that you're working on the airway and improving their health along the pathway in your orthodontic process is what we focus on every single day. And so we've collected this data, and then we really got busy with collecting data. But in a busy practice where you see 80 patients a day, we finally had to buy 3 different machines, one each for our treatment coordinator rooms and one for the clinic. We have a hard time getting every patient in there and testing them all the time. And so we've got data of, over 1,000 patients, but what we call clean data, where we actually have before treatment and then after expansion data. I finally hired a statistician at the college here to go through all the data and put things together. And so this right here is our results from 347 patients. And what I looked at is says, okay, so out of those 347 patients, what is the minimum cross-sectional area change of the whole group? And if you look down at the all, where it says N347, we had about 1.2 millimeters of minimal cross-sectional area for the right and the left side. And then I said, well, what about the top 200 patients, the ones that had the better results? How were they? And they were about 1.7 millimeters. I said, well, what about the top 100 patients? And those are around 2.3 to 2.4 millimeters. You might not think that's a lot, but this is on the one part of their nasal airway where it's the most constricted. And if you can open up a 1 to 2 millimeter difference in their cross-sectional area, that's a lot less nasal resistance that the patient has to breathe through. And so the statistician, as he went through this, he said, this is significant. He said, this is, and I don't know all the terms of everything, but he said, this is basically putting like a 3-year-old against a full-grown person and saying, this is the change that happens with your treatment. And I was like, wow. And my statistician actually is one of my adult airway patients and sleep apnea patients. So it's kind of fun to have him experiencing this stuff. The minimum cross-sectional area, on there, that's the total amount of volume that was increased on each one of these patients. So of the 347, the average is 1.5 cubic centimeters. That's a dice and a half per nostril. Okay. And then I said, what about the top 200? That's 2.4, almost a whole cubic centimeter. And then of the top 100 patients, it's 3.4. So it's take 3.5 dice in each nasal passage, put it in each nasal passage. That's how much more open the nasal airway is for somebody to breathe. And that's why, you know, as we look at these patients, and I have all these parents coming back and saying, wow, my kid is breathing better. They quit snoring. They're doing better in school. They're getting oxygenated. Their airways have improved a tremendous amount. And so I picked out 3 patients, just went on and looked at 3 patients. And so on this slide right here, this is the before rhinometer readings. And so if you look on the minimum on there, it's got 2.2 and 0.22 centimeters, which is 2.2 millimeters, and 3.2. And so for reference, a 3.2 millimeter airway is the size of a coffee straw. And the volume on this kid was at 3 cubic centimeters and 2.5. And then after expansion, he went to 4.3 and 6 millimeters. So one of them actually got up to the correct, I mean, even an adult, and this kid's not an adult. And his volume went from 6 to, I mean, from the low where he was before, 2.4 and 3.5 up to 6.3 cubic centimeters, and even up to, I think it was close to 8 cubic centimeters. That's a huge difference. I mean, we made a huge difference on that patient. Next patient here, and these are interesting when you see patients like this that come in, they have one nasal airway, and the purple line on this one is 0.15 centimeters. That's a half a coffee straw. The other side wasn't so bad. He was at 4.3. But what's interesting is as you treat these kids, it's almost like the body says, hey, this is not working for me. And when you do expansion, it's almost like the body takes the worst part and makes it better. And sometimes it adjusts the other one. So if we look at this, he went from 0.15 up to 5.4 to 5.8. So he had, God, that's like a 300-400% improvement in his nasal airways. And his volume didn't reach 7 cubic centimeters, but he's up at 6 and 5. And that's a huge improvement, you know, going from 2 and 5 cubic centimeters of air. So the volume really didn't change on one of them, but it changed dramatically on the one that was the worst. And then the next patient right in here, on this patient, both of the airways were down around 2 millimeters of minimum cross-sectional area, and cubic centimeters was around 2.5 cubic centimeters. And then with the expansion that I'll show you later on, they, in this patient, increased up to 4. So about 100% improvement, 2.2 to 2.3 up to 4.6, 4.7. And then the volume went from a 2.4 to a 3.5 and a 4.9. And so again, you know, just some really impressive. And this happens to us on a daily basis. It's kind of fun when the parents are, you know, we have now parents who are saying, hey, I want to see what my results are on my kid, because we test them over and over, and then we give them printouts and they can take them home. So I want to tell you how we went from treating on the orthodontic standard of 7 and 8-year-olds down to 3-year-olds. This right here is my granddaughter, Everly. And I was off in Canada at a infant frenectomy course, and my daughter calls us and says, Everly is not sleeping through the night. We videotaped her stopping breathing multiple times. And she wakes up like 7 or 8 times a night. And then she has these meltdowns through the day. She's potty trained during the day, but at nighttime she still wets the bed. And they said, and she's constantly mouth breathing. And so we came back and we said, well, let's take the lower expander that we've been using, which is a lot smaller in dimensions, and let's refabricate this and make it a maxillary expander. And when we did that, we named this the Everly Expander. And so here's Everly, and here's her Ceph. When we took her records, and unfortunately we had a hard drive crash after this and we lost all of her stuff, but I still had this picture. Her tonsils were touching the back of her throat. As a mouth breather, I mean, she had a horrible airway. And this was her airway off of our CBCT. And so both nasal airways and oral airways were just horrible on her. And so we put a little expander in her, and then we did the expansion. She got this huge gap in her front teeth. And lo and behold, underneath her tongue, she's got a little posterior tongue tie. Those are not my fingers, that's her mom's. But we expanded her, and within 2 weeks, her airways and her sleep pattern had been changed. And she went from having night terrors to never not having night terrors. What was interesting is they have dogs in their house. And after we did the expansion, she started complaining about the dogs and their smell, yet she had grown up with them. She had never smelled through her nose to know that what a dog smelled like. Now she sleeps through the night. She wakes up refreshed and happy, and her bedwetting stopped. And I see this all the times with patients nowadays. I even see teenagers. I get sent teenagers from the urologist that can't figure out why a 15-year-old is bedwetting. We go in there and check his airways and he's not breathing. We expand him, and a month later, his bedwetting stops. So, all right. So what do I do to, what's my process in evaluating these patients? They first come in for a clinical exam, and at that point, we do the rhinometer and pharyngometer, and we show them those. And then we do a pediatric health questionnaire, and we take the full set of records with the CBCT, airway analysis, pano analysis. I do the Steiner analysis on the Ceph analysis. And we take digital models and we measure the width of the palate, get their classification of their bite. And like I said, we use the acoustic rhinometer and that. And I can get this to anybody, but this is our pediatric health questionnaire. And they put it on there. No occurrence is 0, rarely occurs as 1, 2 is 2 to 4 times a week, or 3 is 5 to 7 times a week. And the things that I'm looking at is the things that tell me that this kid's breathing through their mouth and not through their nose. And then we can have the parents fill these things out, and then also speech issues that go along with it. The CBCT is amazing. It is not a diagnostic tool of sleep apnea, but it just tells you how big things are when somebody's awake. Then you can compare that to things that are later. We do the Ceph analysis. This is kind of outdated as far as looking at the airways now with the CBCTs. Model analysis, I think, is amazing, because now we got enough data and enough people are looking at things that we know that the palatal width of a patient should be anywhere from 38 to 42 millimeters, depending on the size of the person. On this patient, they started out with a 22.8 millimeter width of the palate, measuring at the CEJ of the 6-year molars. And you can see all the crowding and the open bite and that on the patient. And here's the patient at the end of treatment, 35.7 millimeters. This is one of the policemen, and I know this is an adult, but this is a policeman that we treated. And it was interesting that he came back after it expanded him and grown his jaws. And he came back and he says, wow, he says, I could never chase down these criminals. I couldn't even last a block. He says, the other day, I had this druggie that took off and ran. He says, I chased him for 5 blocks and I took him down. He says, and I still had air to go. So whether you're a little kid or you're a police officer that has a little tiny jaw, airways make a big difference on every aspect of our lives. And so when I look at our treatment planning, it's really simple. Kids that are under 6 years old, 3 to 6 years old, they're going to get an Everly expander. Between 7 and 10 years old, when they've got their permanent teeth coming in, That's when we start using an RPE on the upper and a flea, which is a fixed lingual expansion appliance. Then we put upper and lower brackets on, and depending on their bite, that's when we look at using the forceps springs to grow the bottom jaw forward. After about 11 years old, when they've got all their permanent teeth in, 11 to 18 years old, then we're using an expander and braces, and we put buttons for what we call crossbite elastics. So I'll show you a lot of this stuff here. So this is our Everly expander, and we just put it on the primary D's and E's, and then we just expand them 8 millimeters. The one that I use, each turn is 1/4 millimeter. And so it takes 32 turns to go 8 millimeters. And so we turn once a day for 32 days. And then we tie it off and it sits there for 6 months and we don't do anything. It's the simplest appliance to get in there. Doesn't take compliance on the patient's part. And it just stays there. And then it gives you time for that palate to, grow the bone across the palate. Once we get into interceptive 1B, then we use the flea, which is here on the left, and then the expander, and we grow the jaws. Then we do what's called upper lower 2x6s. Once they get into the adult dentition, I don't use the flea anymore. What I do is we put the braces on, and then we put some buttons on the lingual of the lower incisors, and we use crossbite elastics to upright those buccal segments and get them to match up. And then my tool of choice, and I know there's a lot of tools out there, are the forceps springs. And when we put these guys on, they're usually on for about 6 months, and there's different lengths of them. And as you do that, expand, or you put these springs in, you can get that lower jaw to grow and develop. Kids that have class 3s, this is the reversible headgear. There's different ones out there. I don't think it makes much of a difference as long as you're doing one that can do that protractive thing. I throw one little thing in here where we deal with a lot of these kids with sleep disorders and that. And I just updated this next slide, but child obesity is huge, and we have a lot of kids that are overweight and they're struggling with breathing, and sometimes we don't get really good results. And we got these kids that are obese. And when you look at the prevalence of obesity in our country, from the 70s, it was 4% of the kids. And now it's 20%, 20 to 22% of kids today are considered obese. And so if you don't get really good results on, doing your expansion, sometimes it's because you got obesity, but you also got allergies and things like that. Treatment for the airways of the lower jaw deficiency, my tool of choice is the forceps springs. It's just worked great in my hands for years, but I know there's people like the BioBlock and Twin Block and Herbst. Do not use headgear. I have multiple patients that I used headgear on 20 years ago that are now back as my airway patients, and I'm undoing that retraction that I did on them years ago. And so I live up to it. When a patient walks in, I said, I think I was the contributor to this, to your airway problems. And so the thing that I see is most pediatric airway patients are class 2, and most have underdeveloped arches, and most of them are tongue-tied. And so I'm going to go through some cases here really quick. So this is one of my patients that I treated, big class 2, not enough room for his teeth to erupt. And you can just see how narrow those jaws were. And here he is in the middle of treatment with that big gap. There's the expansion that we created with him, doing those. And then kind of the end results of this. Look how much space for the tongue that's got in there, that big upper jaw. I think it's a nice result. Just looking at our Panorex and how much we developed everything. Here's our before and after uppers and lowers. Development. I look at the main thing is this kid was a complete mouth breather. Now he's a nasal breather. Doesn't snore anymore. Fully corrected his class 2 bite. We have a lot of these severe class 2 patients that come in and not enough room for their teeth, cross bites, and lower jaw that sits way back. And you look at what we can accomplish now by helping that bottom jaw to grow forward to match up with the upper jaw. There's our end results. Look at how much space that tongue can totally fit inside of the mandible now. And so again, complete cessation of snoring, no more sleep disorder breathing, never tested him for sleep apnea, but hopefully never need to. And then with our class 3 patients, this is what I got my master's degree on, is face mask protraction. And so this is one of our patients that I think he had macroglossia, total mouth breather, but he positioned his jaw forward instead of dropping his jaw, and he created an underbite, and he had a tongue thrust. And so this is his beginning photos here, big open bite, no control of his tongue, and that tongue didn't fit inside of his jaws. And here he is in the middle of treatment, growing and developing everything. We use the reverse pole protraction headgear. Bracket positioning is really important to close the bite. You put those brackets closer to the gingiva. And we had an exceptionally phenomenal compliant patient. And here he is at the end. And a little more room for that tongue. I think his tongue's still big. And then full correction of his class 3. And then, why do we treat kids so small? Because we can accomplish so much when they're growing and developing. You want to catch them in that early stage. And the most significant changes is during these formative years. You can correct so much when they're in their big growth spurts. And so kind of the conclusion on all this is, are we tooth technicians or are we doctors? And I think before I was a tooth technician as an orthodontist, and now I look at the total health of our patients, and I'm much more looking at the total whole person. So there you go. You guys just got 100 slides, and it took a while. So Lauren,
you did a great job. Thank you so much. Why don't you stop sharing the screen?
There we go.
That would be terrific, because we do have some questions. But wow, it's amazing how many lives you have changed and saved over these 30 years, right? I mean, how many patients do you see a day typically that you're doing expansion on?
Oh, a slow day is 60, and we'll see 90 patients some days.
Wow. And you are booked out, right? So this is like
we can't get a new patient in until I think we're now out to Thanksgiving. So
and you're in a city, right?
We're in a town.
Right. No, I know. I know you're very rural.
We are very rural. We're in Podunk, Idaho, Lewiston, Idaho, population 30,000.
Wow.
2 other orthodontists here. And I have patients that travel 8-10 hours. I have 2 families that fly from Texas up here to see me with their one with their kids and one as an adult. I have patients that come from California and Portland and all over the place, and I don't have the time to take care of everybody. So I'd much rather train everybody else, and they can take care of them where they're at.
Right. Amazing. So we're going to go to some questions here too. In the beginning, when you were showing that table, are the airway spaces the desirable size that you were showing? Maybe we can answer that in the follow-up email. I'll go back. I didn't want to interrupt you during your presentation, but there was a specific slide that popped up with the tables.
Yeah, the tables that's where the airway should be at that.
Okay. Mm-hmm.
So when you look at those, it's like when you look at the minimum cross-sectional area, that's where an airway should be at that age. Perfect. And as you go up, you don't expect a 3-year-old to have an 8-year-old's airway. And so, as we look at little kids, it's like, them having a 3 millimeter breathing through a coffee straw at 2 and 3 years old is normal. But that your body at 12 years old couldn't handle breathing through a coffee straw, but you can at that age. So having that data is really, really key, helping parents understand, why their kid is struggling.
And then someone's interested to know if you expand and bring forward, and if the patient has an Eiffel Tower tongue tie, which prevents the mandible from growing forward, do you see a lot of Eiffel Towers in your practice?
Absolutely. Yeah, we see a lot of those. like every week we're correcting, I mean, most weeks we're correcting probably 5 tongue ties a week. We've had weeks when it's been the whole, I schedule my Thursdays as just surgery days. And so sometimes we'll have 10. But you know, with all of the little kids, I don't do tongue tie releases on kids over 2 years old unless they go with a myofunctional therapist. I did originally, and then I found that they didn't have good follow-up and good function. And I'm not in this to do procedures. I'm in there to have the best results. And so if a patient says, well, I'm just not going to do the myofunctional therapy, and I'll say, well, then I don't feel comfortable doing the tongue tie because it's not going to be successful. But we still do a ton. And I have people that I had people came clear from Portland to have me release, and they brought the myofunctional therapist with them. So it's kind of interesting.
I know all the myofunctional therapists are applauding here. How do you measure your width?
I measure the width at the narrowest part between the 6-year molars. Okay. And then I measure the, to know where we are on the mandible, I'll measure the palatal cusp of the 6-year molars on the top, and then I'll measure the central fossa where those guys are supposed to fit in the occlusion on the mandible to see where the mandible matches up with stuff. And that helps you understand how much you got to expand. When you look at expansion and, you know, rapid palatal expansion or super screw or anything like that, with a rapid palatal expander, you've got an 8mm expander. But what I found after measuring all these patients all these years is you do 8mm of expansion, you get 5mm of growth. And so if you have somebody that comes in and they have a 28mm palatal width, they're going to need 2 expanders. And so we put an expander in, we do 8mm of expansion. 6 months later, we take that expander out. Same day, we make a new expander, we put it in there, and away we go again. And but then we also measure their rhinometer and see where they're at to make sure we're getting the results there also.
So piggybacking off of this concept, how do you discuss that it is possible to expand the mandible? Most dentists think it's impossible. That was from a myofunctional therapist.
Okay, let me put this to rest. When you look at the upper jaw, it's really the upper jaw that you're doing the majority of growth. And when you have, anytime you have an upper jaw that is narrow, the buccal segments of the mandible, everything is dumped in. Okay. And so if you get a kid, you know, at a very young age, and you put a slow expander like a flea in it, I think you're getting mainly buccal tooth uprighting. But then as you do that, as those teeth do upright, then the bone follows that. And, you know, when I'm looking, you know, it's like the slide that had all the elastics that were going on there on the teenagers. If you look at all those kids, you know, they've got these super narrow upper jaws and all their teeth are dumped in. And so basically you're uprighting those teeth and standing them up in the bone. I don't know if you're really growing the mandible in width, but you're definitely taking those bottom teeth and uprighting them. And I think, you know, people that say, oh, you're growing the mandible, really, you're just uprighting the teeth to match that super deficient maxilla.
Right, and uprighting got such a bad rap, but it's actually very effective.
Why would that get a bad rap?
It does. It just gets a bad rap where they're saying it's not true expansion. It's just one of those things.
Whether it's true expansion or it's uprighting, you're getting the occlusion and the teeth centered in the bone. You know, if your bone's sitting here and your tooth is sitting like this, tipped in towards your tongue, is that a natural position for the tooth? No. The natural position is that tooth sitting straight up and down in the bone. And so whether you know, I look at it and say, this is not where it should be. And that's where everybody is. I mean, take your CBCTs and look at those teeth. They're tilted in. You take them and sit them up. They're sitting in the bone where they're supposed to be.
Great. So, thank you for clarifying that. How do you do the releases?
On the tongue ties?
Yes.
Okay. On babies, we do a frenectomy. And it's very quick and simple. We release it. I have a full team that we get it done. And it's just a frenectomy. I go up and down the frenum and then release side to side, and then I make sure that tongue can lift up. Anybody past a year old, I do what's called a functional frenuloplasty that I learned from Srusagi. And I used to do frenectomies on people, and the scar tissue that happened that came back was horrible. And so with a functional frenuloplasty, what we do is we have them do the suction hold where they're sucking their tongue to the roof of their mouth, and they have to be able to do that for me to do the surgery. Now, if you got somebody that's got an anterior tongue tie, you're going to probably do a two-stage release where you're going to release the tongue tie, have them work with a myofunctional therapist until they can get that, and then they're going to come back and you're going to do a functional frenuloplasty later. But as they hold that tongue up, then you can completely release all along the frenum, and then you do a lateral release so that tissue relaxes and that tongue can go even longer. And then you take the that lateral tissue and you bring it back and you suture it closed. Suturing that stuff closed, what I learned from Srusagi is a game changer as far as healing and the smoothness underneath the tongue and the scar tissue. You just don't get that scar tissue and that relapse that you used to do when you did a frenectomy. So
and where do you recommend a doctor learns how to release tongue tie, lip tie?
Well, we put on a course here in my office. Last one we did, we scheduled 24 patients, and it was a crazy day. I don't think I'll ever do 24 patients again. But we do those, and then we go through a didactic part of it, and then we have a multitude of patients. We try to have babies there. We have kids in their youth, and we have adults, and show everything. If you have an Idaho license, and you can get, and we can get a release. One of them that I gave, I had a bunch of the doctors from Idaho come, and they were able to, with the patient agreeing that they could do it in my direction, they were able to do the releases in my practice, which is really cool, having that hands-on. Dr. Zagi, I think, is a great course to go to. He's the one that kind of pioneered the functional frenuloplasty. So, and I've had some patients that have gone to other doctors that have been trained by Dr. Zagi and had great results. So, we we have courses. He has courses. There's different ones out there. I would stay away from just frenectomies on anybody over 2-3 years old, just because of the healing, and you get a much better result. But you're not going to, and on a baby, you're going to get in there and get it taken care of. But then you have to have parents that know how to do the stretches and the rubs and everything like that to make sure it heals. They're the myofunctional therapist. So.
And what laser do you use?
I use the light scalpel and love it. That right there, hands down. I haven't used many there. I used to use a electrocautery. Leaves just path everywhere and burnt tissue, and with a laser it just evaporates and it's clean, and you don't have that that char layer. It's just nice. So
you recommend expanding first and then the laser tongue tie?
Okay, I do not do the tongue ties until you have tongue space. That's a big thing with my myofunctional therapist that I've worked with. Is we used to say, okay, the adults come in and kids come in and say, all right, we're starting this treatment. On kids, we don't do the expansion until the expander comes out, or we don't do the frenectomies until the expander comes out, because some of the myofunctional therapies, you've got to do that suction hold. You got to push that tongue in the palate. You can't do that with an expander in there. And so you've got to wait until the expander is out. But then also, like with my adult patients that I send to my myofunctional therapist, I used to send them there early on, and she'd send them back and say they don't have enough tongue space. And they have to have tongue space to push their tongue in the roof of their mouth to have things successful. So wait until we have that palatal width corrected. And then when we send them, then they can do the correct myofunctional therapy.
Okay. And how many myofunctional therapy visits do most patients need prior to the frenectomy?
My two myofunctional therapists that I work with have 2 visits first. They have an initial visit, and then they work with them on that suction hold to make sure they can do the suction hold. That's kind of the big things. And then they do a full evaluation so that they know where they're looking to get after that.
What is the earliest age you can place an expander? You had the range starting from 3, but have you ever placed earlier?
I've placed it on 2-year-olds. That's hard. It's just their mental capacity to handle it and having enough teeth. One of the first 2-year-olds that I did, I'd already treated 3 kids in the family with expansion, and this mom had a 2-year-old that was just completely wild. And the whole time, every time she came in, he was mouth breathing, he was bouncing off the walls. And she says, he does not sleep. And she says, can you expand him? Because I want what you did with my other kids to happen to him. And I says, he's not going to hold still. She jumped in the chair, put him on her lap, put her arms around this kid, put her legs around his legs and says, I don't care, do whatever you have to do. I can't take it anymore. And she was about ready to give this kid up for adoption. And we had our staff, we got in there, we fit the bands, we took an impression, we got the appliance made, we put it in, and this little kid took it out, I think 3 times, you know, in the year process of that, but we got him expanded and we changed his life, and he would come in and sit with his mother instead of bouncing off the walls. And to this day, she thinks that we walk on water. That was probably one of the hardest things we ever did, because we didn't have a cooperative patient, and
Right.
that's hard.
Okay. So maybe it's a trick question, but someone wants to know when to extract.
Extract what?
I guess when is extraction? I'm elaborating on this question, but when would you recommend extractive or orthodontics?
I haven't had to do that in 10 years. Even on my adults, I had a lady come in today that's in her 40s and 50s, and she has a 27mm width palate, and she has a 3-year-old airway, and she's came to me for a second opinion, and she's got all these sympathetic nervous system problems that she's having. I said, my treatment will be probably 2 years or more of slow expansion with a Schwartz appliance before we ever put a bracket on there. But I've got hundreds of patients that I'm a Schwartz appliance patient. I expanded my palate 8mm in a year and a half and completely changed my sleep. And so I did it as an experiment because I was treating all these other patients and I didn't realize I had bad sleep, but I used to get up and pee twice at night, and now I don't ever get up anymore. And this lady looked at me and she says, wow, so it's not about the teeth. I says, no, this is nothing about the teeth. This is about everything else that's going on around you. And if you'll give me a very slow process for an adult, we will go in and we'll grow your jaws. And in the end, we won't take out teeth. So, but you have to be to do it.
Yeah. What are some good questions to ask local orthodontists in order to get an idea about whether or not they are airway centric?
Oh, that's hard, because most orthodontists in the world, and even the 2 orthodontists that are in our town, you know, they're still stuck in that traditional. One guy says he's an airway guy. He understands airways, but he still extracts teeth. And I think
so. If you would have one question, would it be fair to ask if they do extractions? Is that?
Yeah, I mean, how would you know if you had an airway patient? I mean, you know, ask them. Yeah. How do you know if your patient has an airway issue? If they can't answer that, you know, then they're not an airway centric orthodontist.
Great. And how many millimeters do you usually expand a person, adult child's palate, to get the best results to open up the airway?
That all depends on the patient. You know, if I have a little kid that comes in, that one case that I showed you, that the adult case on the models, he started at 22mm. He now we did things different. He went and had a surgically assisted RPE, and we did 2 RPEs, and then we did 2 Schwartz appliances. So he had 4 expanders to get him to 35mm of expansion and getting his jaw where it was supposed to be. So it's not one and done. Some patients are, if they come in with a 32, 34 millimeter width of their palate and their airways are 4, millimeters in the cross-sectional area, one expander is going to get them to normal. But if they come in under 30 millimeters, you're going to probably be doing 2 expanders. And even with our adult patients, we look at them and say, you've got a 28 millimeter width of your palate. We're going to get maybe 4 millimeters of expansion with a Schwartz, and just to get to you to 38 millimeters is going to be at least 3 appliances. And so, before I was ever doing any of this stuff, it was one and done. You put one in there and you did it, and you were happy that you got some space. So.
Well, there are so many questions that we're going to have you come back. And I know you love sharing your knowledge, so I don't think that's going to be an issue. And it wasn't so scary, right, Dr. Christensen?
Well, I can't see everybody's
you did a great
faces.
job.
Yeah, I can't see everybody's faces that are out there, but I don't know. I hope that I just hope that I can change the thought process. And here's the thing: I would love to speak at the American Association of Orthodontics, one of their big meetings, and talk about this, but they'll never invite me because they just won't. But what I would tell them is orthodontics is going to dry on the vine. The profession of orthodontics is going to dry up because, number one, the aligner stuff that people are doing, that is taking a big market share of orthodontist. People can order stuff off of the internet, which I don't agree with, and they can have somebody do aligner stuff and make their teeth straight, and they think it's fine. But here's the thing: is the general dentists, they get airways, and they are going to do this whether the orthodontist does it or not. And if the orthodontist doesn't take it, they're going to lose their profession, because there's other ways to straighten teeth that don't require an orthodontist. And so if an orthodontist is really going to if we're going to hold the profession, we have to become doctors. We need to become doctors of the whole craniofacial complex, not tooth technicians that make teeth straight. And I think in the next 10 years, I'm helping general dentists to do orthodontics. Why? Because my orthodontic colleagues won't listen to it, and they say, "Oh, this is voodoo. You can't grow an adult." And I'm like, "Come and see my patients. I'm an open book."
We'll show the adult patients next. And just stay with me for a little bit, because I do want to give some updates here on what's coming up and what's next. I'm so thrilled about this mini residency that we have coming up on May 5th. I know a lot of you asked the questions that were technique based on how. So we did put a course together. It's a one-day course, so you can learn. Orthodontists are welcome, general and pediatric dentists. It is a technique course, so this is a doctor-only course, but you can learn more at our website, airwayhealthsolutions.com/Christensen. All of this will be in your follow-up email. Really, if you just want to dive in and learn about pediatric and adult expansion, as well as clear aligner therapy, we do have upcoming mini residencies. Our next one's October 21st. That's almost sold out. And November 4th is filling up quickly. So if you're serious about learning this, please consider joining one of those mini residencies as well. Every guest that we have on in Airway really talks about myo and how not only important it is, but necessary. So we do have courses that we offer for hygienists to become myofunctional therapists, for existing myofunctional therapists, and also to integrate myofunctional therapy into the doctor schedule, into the doctor integration. So we're having a flash sale. It's not a flash really, because we're extending it all through October, because it is National Dental Hygiene Month and Orthodontic Health Month. So what other better time to do that than this month? So please learn more, again, at our website as well. We have an advanced mini residency with Dr. Boyd. I know, Dr. Christensen, you took that live last year, and you added to that as well. So that'll be live January 27th and 28th, where he is teaching specifically under 7-year-olds the techniques as well. It is an advanced course, so we do recommend that you take the Dr. Morales mini residency beforehand, or Dr. Christensen's as well. Dr. Moralia has an advanced mini residency where we talk about fixed expansion in older teens, as well as bracket and wires using an expansive technique. That's coming up in March. It's 100% virtual. And then we have Dr. Gelb, our TMD to ortho, treating with TMD patient. It gets the patient ready for orthodontics. That's a virtual course on March 31st. And then I'm so excited. I know, Dr. Christensen, you're excited as well for this. You'll be presenting twice on some of the data and some really remarkable cases. But this Airway Palooza is really an event like no other. We're kind of all getting together and celebrating just this airway health movement. We're so excited to have James Nestor there. He's doing a special keynote just for us for the movers and the shakers, the doers in airway. So it's really a big celebration because we are taking the road less traveled, and we just wanted to celebrate our airway dentists. And now we invited other allied health professionals as well. So we will send you that information so you can all register and join us in Savannah, which is a great town. We do want to thank our sponsors, Light Scalpel and Sleep Group Solutions, for sponsoring the Palooza, as well as Ollendorf Appliance Lab. Here is the, if you go to the Palooza, we can, we have it for the doctors. We do have some perks. So this will be in the follow-up email. I know it's getting late, so I want to be respectful, but I want to make sure you understand our specials, because today is the last day, if you are an allied health professional or a team member, that you can have your interest-free payment option. You have to have it registered by today, and then you can have your payments divided into 3 monthly payments. So if that sounds interesting to you, reach out to me, or you can sign up directly through that link. It's airwayhealthsolutions.com/Palooza AHP. And if you don't have a myofunctional therapist but want to do myofunctional therapy, we highly recommend Brittany Sierra, actually Murphy. She got married, so she does telehealth myofunctional therapy and is wonderful with the adults and the kids. So reach out to me. Once you take our mini residency, you do become part of our airway dentist family, I like to call it. And I love seeing all these green dots. We actually have a few more, but we're also global. So we have our global friends here. If you're looking for an airway dentist, please find airwayhealthsolutions.com/locator. I know there's a lot of myofunctional therapists on today. It's a great way for you to network, perhaps plug in your zip code and you can contact people, because it's always nice to have live attention when needed. And we do have our airway aligners. Once you take our mini residency with Dr. Moralia, you are eligible for that. And it's his tried and true algorithms designed specifically for you for each case to make sure it's an expansion case. And that's what we partnered up with Ollendorf, Kevin Ollendorf of Ollendorf Appliance Lab. So we have a lot of solutions. That's why we call ourselves Airway Health Solutions. We do have our Facebook group for those who've taken our mini residency. I hope you do join that so we can really share and collaborate. We have our quarterly town hall. And if you haven't taken our mini residency, we do have our Airway Health meetup, which is good, open for everybody. So please join us so we can share all of our thoughts and tips and tricks. Our next Airway Health Solution conversation is November 2nd with Dr. Kevin Boyd. He's going to give us some early childhood case reviews. And then January 18th, Demystifying TMD with Dr. Michael Gelb. And we have other guests lined up already. So I'll share that with you once I have them. But that's a wrap. And I thank everyone for their attention. Dr. Christensen, I really thank you for the work you do. And the more important, the data-driven orthodontics, that's really what's going to change it, is the data. And you have so much to offer. And we're so glad we found you. I want to give a shout out to Dr. Scott Province for introducing me to you. I know Sleep Group Solutions, the folks over there, for really collaborating to get the message across. Thank you, everybody, for doing what you do. Let's continue to do it. And we're helping more people breathe, sleep, and thrive. And what a better way to have you call it a job. It's not a job, it's a mission. So thank you, everybody. Dr. Christensen, why don't you close us out with some words of encouragement from an orthodontist who's a specialist in airway for 30 years?
Oh, gosh.
I'm sorry to put you on the spot, but
Well,
can't
no,
help it.
It's just, I think it's, it's just so rewarding to be able to see the difference in these patients. That's what I live for every single day. It's not the paycheck, it's the experiences that I experience every day with my patients. These parents that come in and they just, they're what make what I do important. My wife would like me to retire sometime, and I said, why? I love what I do. I'm going to stay here and, for a while. I am looking for an associate. If
Yeah.
anybody knows of an orthodontist that would love to come to Idaho, I am so busy and I need an associate. And so anybody's got some feelers out
Need
there.
to be an orthodontist? Can it be an airway pediatric dentist or a dentist? Do you want it 100% orthodontist? I just want to throw it out there.
We could probably do it that way, but I mean, it'd be nice if they're an orthodontist. I thought about having, a general dentist coming in here, but we're not set up to do general dentistry.
Right.
And the big things is when I'm doing a consult on an airway patients, which we're doing, about 10 a day now, that takes me out of the clinic, and then I get behind in the clinic. And so I just hate being behind. I need somebody.
That's where you are again, so people know.
Lewiston, Idaho. It's right next to Bear Poop, Idaho.
Okay, so
It's an awesome
that would
place.
be an opportunity of a lifetime.
I love fishing and hunting and outdoorsy stuff and river water stuff. We're the place to be. I mean, we've got 2 rivers next to us. I mean, hunting is 20 minutes from us. Fishing is just galore. Everybody travels here to do all of those things. We just don't have a lot of people, which is why I like it here.
Well, it would be an incredible experience. So I know we're over time, but I wanted to make sure we could answer as many questions as we can. We'll definitely have you come back. Thanks again, and everyone have a wonderful night. Take care. See you next time.